Now, as clinicians, we are in this position where you reach the 2 years, the patient is doing well, and you raise the possibility of stopping the checkpoint inhibitor and kind of monitoring closely versus continuing it. And there is that potential in the future where a liquid biopsy or circulating tumor DNA may help us with some of those type of decisions.
That's Dr. Nicholas Bodor, an assistant professor at the Department of Hematology and Oncology at Fox Chase Cancer Center in Pennsylvania. He'll be along later in the show. This time on Cancer Buzz, liquid biopsies, their current clinical applications, reimbursement issues to consider, and what you need to know about this important tool for enabling precision medicine. Welcome to Cancer Buzz. I'm your host, Summer Johnson. Less than 5 years ago, the FDA approved the first liquid biopsy test for use in patients with cancer. Before that, oncologists relied entirely on invasive procedures to obtain biopsies, which themselves bring a host of challenges and can't be used for all patients. Enter new technologies that can gather genetic information more efficiently. Tests like liquid biopsy are less invasive and can not only detect disease, but also provide specific information for precision care. You heard from Dr. Bodor earlier in the show. We turned to him to discuss how he's using liquid biopsies and the considerations providers have to account for.
We practice in an era where personalized precision medicine is absolutely key when it comes to cancer care. And this is especially pertinent and important in the field that I practice in, which is in lung cancer, where we have at least 7 potential targetable mutations where we have FDA-approved medications that can be highly efficacious for patients. So it's of utmost importance that we do exhaustive testing for these potential driver mutations for which we have drugs for. And so the historic gold standard really has been this tissue-based testing, which is what we've been relying on. Involves, frequently single gene testing, although more recently we've moved towards the direction of more comprehensive panel-based next generation sequencing profiles. But we, frequently run into these issues that I think many oncologists frequently encounter where tissue may not be available, might not be available right away. The tissue specimen itself might be degraded, or there might not be a sufficient amount to run the additional molecular testing that is required. And so the emergence of liquid biopsies or blood-based assessments of circulating tumor DNA in the last couple of years has truly been an exciting development because it gives us an additional tool in which to look for some of these potential driver mutations, which of course is of utmost importance, especially in the context of metastatic non-small cell lung cancer, where we're trying to make the best first-line therapy options for our patients.
I would imagine, too, that there are other advantages. For instance, they're less invasive. Does that mean that you can have these tests more often?
Yes, it is less invasive. It's usually something I get when I first meet the patient. So the very first clinic visit, I'll have my nurse, after we go through the clinic visit, draw the blood from the patient. And there's something very powerful about knowing that you're starting that very important workup, that very first day where you're meeting that patient with a relatively quick and easy and non-invasive test, which is a blood draw, and then you send it off to get the next generation sequencing done on the circulating tumor DNA. And the prior studies have found that the turnaround for liquid-based testing is likely significantly faster than tissue-based tests. The prior studies have indicated, median turnaround time to results of about 9 days. And that is certainly what I've experienced in my own practice. And in fact, there are times when the results can probably come back as soon as a week, which is a very powerful thing because, anytime an individual is diagnosed with a metastatic non-small cell lung cancer, there's a lot of anxiety involved, and frequently patients present symptomatically. So it is important that we try to get that answer as quickly as possible.
What do you think are some common challenges to liquid biopsies?
That is a good question. And this is probably one of the biggest challenges and probably one of the more major limitations, and something I do want to emphasize when it comes to liquid biopsies. Yes, it is a very powerful tool. Prior studies have indicated that it is a highly specific test. meaning that if you get a positive result, if you identify a targetable mutation using a plasmid-based test, it has high positive predictive value. The likelihood of that being a false positive is very low, and that you can trust that result and you can prescribe medicines and therapies based off that result. However, one of the biggest challenges and limitations of this particular form of biopsy is that there is that risk of a false negative. And that's largely due to this phenomenon called insufficient tumor shedding. In these instances where you might have a patient with metastatic disease, their tumor burden may be low enough. They might have disease that's confined solely to the chest, or they might have a more oligometastatic disease to a single site like the brain. In these instances, we cannot be confident that there is sufficient circulating tumor DNA by which to assess for these targetable mutations. I must say for these patients, I still do send the liquid biopsy that first day in clinic. However, I definitely have in the back of my mind that if that result comes back in a week as being negative, that is not where I stop. That is the limitation of this test, and I recognize that. And I make sure that the tissue-based testing, if not already sent, is definitely sent at that point, because it is important to kind of reflex and get that tissue-based testing, because there still very well might be an actionable mutation when you test the actual tumor.
What about the future? What should community oncology teams expect about the application of liquid biopsies and in biomarker testing going forward? I imagine that we're going to see these tests expand beyond NSCLC.
Yes, it's a very exciting time. I mean, currently, as far as the clinical application, it's largely been used in the metastatic setting, primarily in the first-line treatment of metastatic non-small cell lung cancer. But certainly the application can extend beyond that. I have colleagues who frequently check liquid-based testing at the time of progression to look for other mutations or other potential resistance mutations for patients who are already on targeted therapy. But it goes beyond non-small cell lung cancer. Certainly in other forms of cancer, including prostate and colon and breast cancer, there's been a lot of research in regards to liquid biopsy. In prostate cancer specifically, with castrate-resistant prostate cancer, there is a FDA approval in regards to using a liquid-based panel looking for the appropriate use of PARP inhibitors. But there's also a number of studies in other cancer types as well, looking at the application of liquid biopsies. And as far as what the future holds, there's a great deal of work going on, and I can certainly foresee a future where we're not just using this at the time of initial presentation, looking for driver mutations.
Where can you see liquid biopsy really changing the game for treatment decisions?
This is not just about patients with targetable mutations and targeted medications for. This can also be extended into the realm of the use of immunotherapy and checkpoint inhibitors, because certainly immunotherapy is our go-to in the first line for any patient without a targetable driver mutation. And the scenario that many oncologists are starting to face now, and this is very much a good thing, is that we have patients now who are living longer than ever on immunotherapy, and they may be on the checkpoint inhibitor at 2 years, and frequently on those prior clinical trials, the immunotherapy was stopped at 2 years. And now as clinicians, we are in this position where you reach the 2 years, the patient is doing well, and you raise the possibility of stopping the checkpoint inhibitor and kind of monitoring closely versus continuing it. And there is that potential in the future where a liquid biopsy or circulating tumor DNA may help us with some of those type of decisions. The additional point that I would like to emphasize is the importance of getting the molecular testing upfront. I do want to emphasize that in this never smoking or light smoking lung cancer population, because immunotherapy is very much moved into the front line for a lot of our patients, and specifically for the patients that do not have an EGFR or ALK mutation. However, there is an important caveat with that. Immunotherapy, especially as a single agent, there are a number of studies and a lot of evidence showing that single agent immunotherapy is not effective in patients with some of these driver mutations like EGFR and ALK. And in fact, even in patients with EGFR mutations who might come back with a high PD-L1 level greater than 50%, where we frequently would prescribe an immunotherapy agent as monotherapy, is not the right answer for these EGFR mutated patients, because we have found that PD-L1 does not necessarily correlate in these EGFR patients. And ultimately, immunotherapy is not the best form of therapy for these patients with driver mutations. Really highlighting the fact that it's important to do all the exhaustive testing up front and try to get our answer quickly so that we can identify these targets and treat appropriately. And then the last point I do want to make about that as well is immunotherapy, in particular in patients with driving mutations, specifically EGFR. If you give immunotherapy prior to a tyrosine kinase inhibitor, there is a great deal of evidence that when you start the tyrosine kinase inhibitor, after that EGFR mutation was found, several weeks later, and they've already been started on immunotherapy, their risk for toxicities, in particular things like pneumonitis and colitis, are significantly greater if they've already received some immunotherapy prior to the starting of a tyrosine kinase inhibitor.
Now we turn to barriers to the widespread adoption of liquid biopsies. ACCC surveyed cancer team members most likely to order a liquid biopsy. 61% of them said that the processes and procedures for ordering these tests need to be improved. And liquid biopsies aren't cheap. Reimbursement for them can be unpredictable and confusing. Payers structure their coverage in different ways, sometimes only reimbursing for specific clinical conditions and tests. Our next guest breaks down reimbursement considerations, current coverage trends, and what to expect. Dr. Kathryn Phillips is a professor of health economics and health service research at the University of California. She's also the founder and director of the UCSF Center for Translational and Policy Research on Personalized Medicine.
For a while now, we've been looking at coverage of tumor sequencing because, as you know, we can now sequence tumors using panels of genes as opposed to only looking at one gene at a time. So this has fundamentally changed the way the payers cover these tests, because historically payers have covered tests based on you're looking for one gene and you're going to use that gene to come up with a treatment plan using one treatment. And of course, multi-gene panels change that paradigm. So we've been seeing a shift in the way the payers are covering tumor sequencing tests. It's a very complex and evolving area, but basically, in the past few years, we've seen much greater coverage of these tumor sequencing panels as a whole. But for example, for private payers, they still tend to have restrictions on what they will cover. For example, they will only cover a particular type of cancer using these multi-gene tests, such as lung cancer. Or they may only cover a certain size of panels. They may only cover those that are under 50 genes.
Now, where has CMS been on coverage?
We have seen a trend towards greater coverage by Medicare, but again, they have a number of restrictions. For example, they will only cover companion diagnostic tests, or they require FDA approval or clearance. So we've been seeing this shift in coverage for tumor sequencing tests as a whole. Now we're seeing the same type of shift to coverage of liquid biopsy tests. We did a study that looked at coverage through 2019, and this paper was published in 2020. So overall, from 2015 to 2019, we saw a big increase in coverage of liquid biopsy. It went from 0% in 2015 for both private payers and for Medicare to 38% coverage for private payers. And Medicare has put out a number of local coverage determinations that do provide coverage for liquid biopsy. So it's been very interesting to see a growth in the number of coverage policies, in the number of policies that are positive in terms of coverage. And we've also seen this very interesting evolution of Medicare coverage, because a lot of the Medicare policies will now cover pan-cancer tests. In other words, liquid biopsies that are used for multiple types of cancers as opposed to only one. But and once again, we see a lot of restrictions to coverage.
Let's talk about those restrictions to coverage.
So, for example, with private payers, frequently their policies are very specific. The majority of them will only cover lung cancer, non-small cell lung cancer. A majority will only cover brand name tests, and they actually name the test in their coverage policy. 43% will cover EGFR testing only. And interestingly, only 11% of private payers as of 2019 had started looking at the use of liquid biopsy for monitoring purposes, which is different than for initial treatment decisions. So that's where we are as of 2019. So maybe I should just go ahead and tell you what we've found there, which has not been published.
Of course, please do. We'd love to hear where we are now.
We are seeing an increase again in coverage by both private payers and Medicare. You notice I don't talk about Medicaid at all. We don't know what Medicaid is doing. Each state is different with Medicaid, but one can probably assume the coverage is much less. But what's happening in private payers and coverage? We now find that 2/3 of private payers explicitly cover liquid biopsy. So that's almost double of what it was in 2019. However, they still have a lot of restrictions. 53% require that tissue be insufficient. Private payers are still frequently restricting to lung cancer, or they require that the patient not have had other multi-gene panel testing before, or they'll name the specific brand name test in their policy. And some still require the panels be less than 50 genes. Medicare has continued to issue local coverage determinations. They don't yet have a national coverage determination, but there have been a lot of local ones that are moving towards this pan-cancer coverage that I mentioned earlier. They're also starting to cover monitoring, and several new policies are focusing on minimal residual disease, which is another important use of liquid biopsy.
Why do you think that reimbursement issues are more complex for liquid biopsy than any other test?
Well, liquid biopsy is a very interesting case study because it's a technology that is different. So it may be trying to achieve essentially the same objective as a tissue-based test with some differences, but overall the same purpose, but it's using a different technology. So whenever you introduce a new technology, I think that introduces some complexities for coverage decisions because payers have to decide, well, should we cover this test and this technology the same as we do other technologies that are for the same purpose? Or is the technology itself different enough that we need to have separate coverage policies? So I think it just adds more complexity. There's the whole issue about where is this going to take us next? And with liquid biopsy, the where is it going to take us next is the use of liquid biopsy for early detection. So payers are always quite interested in knowing what is the trajectory of the use of tests. Will they move from targeted testing to population screening, what they call the slippery slope? So that's something too that payers start to look at when they look at new technologies like liquid biopsy.
According to a recent ACCC survey, the ones most likely to be ordering liquid biopsies would be physician assistants, nurse practitioners, surgeons. But when asked about the processes and procedures, the majority of the survey respondents said it's really complicated. Do you think that confusion leads to a hesitancy in ordering liquid biopsies for patients?
That's a really good point, in that I've been talking about the written coverage policies, but what's in writing doesn't necessarily mean that's what happens in the real world. So payers may state explicitly in their written coverage policy that they do XYZ, but then in the clinic, when these tests get ordered, there may be all types of permutations and differences in the way they actually get ordered and whether then they actually get paid for once the claim is submitted. So I do think it introduces some complexity. One concern is that payers won't cover both tumor sequencing tests using tissue and a test using liquid biopsy. In other words, that they will only cover one or the other. And that is the case, that in writing, this is what often payers will say, that they will only cover liquid biopsy if it's been shown that the tissue is insufficient. In other words, they can't do a tissue-based test. But in reality, it could be payers are going to cover both. So that's where I think a lot of the complexity comes in and a lot of the uncertainty regarding what will be reimbursed.
Thank you to Dr. Bodor and Dr. Phillips for sharing your insights. Check out the show notes for an even deeper dive into liquid biopsies and precision medicine. Thank you for listening to Cancer Buzz. If you like what you've been hearing, leave us a review and share the episode with your colleagues. That helps us grow the show. Next time on Cancer Buzz, ACCC's new president, Krista Nelson, shares her goals for the oncology community post-pandemic. Until then, for the entire Cancer Buzz team, this is Summer Johnson.
Cancer Buzz is a resource of the Association of Community Cancer Centers.